Thank you very much indeed, and welcome back to the second day of the RotorGP Network Conference, where we've had the political session this morning, and I'm delighted to introduce to the chair Chai Chuah, who was ex-CEO of the District Health Board and currently the National Director of the National Business Unit of the National Health Board. Is that right?
It's a mouthful, isn't it?
It did incredibly well, a bit like the cooking. And I've attended most of your message this morning and thoroughly enjoyed it, by the way, as indeed the crowd. I would love, if possible, we've got to sort of condense what you were saying into 10 minutes. So if you were to summarise the message you were trying to get across to people this morning, how would you summarise it in just a few minutes from the very lovely talk you gave?
A couple of keywords then. One is implementation. Second keyword is leadership. And third keyword is innovation. So when I put the three words together, I think we know what we have to do. So we have to concentrate on looking at how we actually implement. But to do that really well, we need leadership all around. But when we're leading and implementing things, we also need to be innovative. And when we talk innovation, what the health sector needs is not sustaining innovation, but what I call more disruptive innovation. And I talked a little bit about that, what that means.
Excellent. So what changes can we on the coal face anticipate to see over the next, say, 10 years? How is it going to look differently?
Oh, well, 10 years. I came across an interesting book recently about what the world will look like actually more in 20 years, but 10 years and 20 years, well, time goes by quickly.
Both young.
Quickly,
we'll be around by then, that's
quickly.
fine.
I think that the whole progress of scientific breakthrough and impact on health, my personal view, will radically change how health is provided. So currently, our health system is moving through a change where we are aware that most healthcare needs to be done not in the hospital, but actually out in the primary care in the community. I think that in the next 10 years, we'll see a much faster progression down that line. The whole emphasis of the individuals and the family community playing a greater role will also play a big part. And I think that we will also see that as people live longer, a greater contribution of the elderly actually playing a part not just with themselves, but actually with each other around how they support each other in terms of their health and well-being.
So for us as rural general practitioners or people working in rural general practice, how do we need to respond to those changes?
I think in many ways, as rural practitioners, you're a lot closer to where the rest of the sector need to go, because you're already working very closely with the rural community, and you already know what it means to actually sort of use all the resources that exist in the community. I guess it's just to watch what's coming down the line. I think particularly around technology. I think that in many ways, the rural practitioners are fast adopters of technology because you have to. And I think in some ways, just watch how we use that. But if you look, but perhaps to look at how technology fits in with the changing nature of the workforce that you're recruiting to come into to work in the rural community. Because I'm sure you're well aware that the younger people coming through have a different interpretation of technology.
Certainly. So you mentioned the word workforce. Are we going to see a different type of workforce, or simply just an expansion of what we've currently got?
I think workforce will need to change anyway, because if you think about the scientific breakthrough and the greater role the individuals and families and community play in the health and well-being. So increasingly, I think, and I remember actually Harry Pert saying to me one day that increasingly I think clinicians will become interpreters and facilitators as opposed to once upon a time, the fountain of all knowledge. And I think that's the role.
That you paid us a great compliment. Certainly, we've all heard the expression, if it ain't broke, don't fix it. I think we've all got our axe to grind on this one. What problems do you see at the moment, if you were to do a snapshot of where we are? What is broke that needs fixing urgently? I mentioned 10 years. How about the next 12 months?
Next 12 months. I talked a little bit about the challenge of the funding, but I think that people get focused on funding too much. I think what we have to manage through, and that's not the next 12 months, perhaps over the next couple of years, is not forget why we're here. We're here really more for improving patient care and well-being and improving access, but taking greater responsibility of how we use the resources. Right? And so there's a New Zealand triple aim, and it talks about those three facets. So as we look forward to the next 12 months, as the funding becomes tighter, there's still an increase, then I think that when the sector responds to that, it's important to remember the New Zealand triple aim. And you can't do one or two, you have to do all three.
That's refreshing to hear. Now, you mentioned leadership before, and it was a lovely talk you gave on leadership. So where do you see that leadership coming from, and how, I suppose the rider to that question is, how can we help you, so to speak, provide that leadership?
I talked a little bit about leadership need to be at multiple levels, and I suppose the obvious place to start is the people who currently hold positions of authority, and I think it's beholding on people like me who hold this authority to actually think about how we exercise that authority and leadership. Because I think that if we exercise it in an autocratic or a cottage-style industry or an industrial era style leadership, it is not what is required. We actually have to exercise a style of leadership much more appropriate for what I call the knowledge-based era, which requires, if you like, leaders to not always need to lead from the front, but be comfortable at times to lead in the middle or even from the back.
So for us as the Royal GP Network, how can we engage with you to sort of steer things through? And I think we've got a vested interest in the primary sector, and you did mention sort of Des Gorman's message as well, the devolution of work from the secondary to the primary sector. So how can we work with you with that one?
Yeah, I think we talk a bit about the progression of where the future lies, about the movement in the health sector, more from moving from the hospital sector to primary and community. It's actually working with those who govern and manage and practice medicine in the secondary sector, about helping them to manage that change and that transition. Because my sense is that intellectually they understand that and they want to be part of that, but it's quite threatening to them.
It is.
Because I think that they have to give up something in order for them to do something different. Likewise, I think for the primary community sector, you have to give up something so that you can actually take something new.
So there's almost a marketing requirement for the necessities of change there. How can you see that being marketed in effect? Because as you rightly say, it will be threatening to many different parts of the sector.
Yeah, I think marketing is probably quite a commercial word, and I think it doesn't work in the health sector. I think what we need is much more of much more opportunities to have genuine conversation and discussion about things that really worries us, things that really threaten us, things that we fear about if we give things up or if we take new things on. Because often I think that we are prepared to talk about those things in general terms, but actually don't go near enough around the real issues that really need to be put on the table, if you were the elephants in the room, and be comfortable to be able to have the robustness of the dialogue so that we can actually collectively look at saying, okay, who needs to give up something and who needs to take something and who else needs to give up something so that somebody else can take something. And it requires a level of maturity, it requires some real strength in leadership to facilitate the right environment for that sort of conversation to take place.
That's well put. Let's completely change tack, if I may, and notwithstanding what you've just said, but if I was to give you a magic wand right now, and you could wave it, and you could see 3 changes instantly tangible with the health system, what would those 3 wishes be?
Next 12 months?
Yes, I'll give you 12 months.
Okay. I'd like to see more opportunities for consumers, patients and their families to play a greater role, to be much more prominent in terms of the changes we're making, in terms of participation early involved in that. That's one. The second one is much more practical, which is there's a big push for clinical integration, more services to be provided in a primary care setting. We cannot invest in 2 places. So if we're going to make the investment in primary care, we have to help our secondary care and hospital colleagues to reduce or manage or stabilize the acute demand. Right? So that's 2. Okay.
Last wish.
Last wish. I'd like us to think about setting the foundation for a more deliberate development of a leadership program for those of us who work in health, and those to follow.
3 gorgeous wishes. Well, I'm afraid we're out of time, but I really must thank you very much indeed for taking your time to come and talk to us today. I really appreciate that. And
Real pleasure
I wish
to
you well
be
with
here.
your 3 wishes.
Yeah. Thank you.
God bless you.
Bye.
Thank you.